The management of acute pancreatitis focuses on supportive care, addressing the underlying cause and preventing complications. Below is an outline of the typical approach. 1. Initial assessment and diagnosis. Confirm diagnosis. Clinical presentation, e.g., epigastric pain radiating to the back, elevated pancreatic enzymes, amylase lipase 3 times the upper limit of normal, and imaging findings, e.g., CT or ultrasound. Severity assessment. Use scoring systems, e.g., Ranson criteria, BISAP score, or Apache 2, and imaging to stratify severity, mild, moderate, or severe. Identify etiology. Common causes include gallstones, alcohol, hypertriglyceridemia, or drug-induced pancreatitis. Investigate with history, labs, and imaging. Hap 2. Supportive care, cornerstone of management, fluid resuscitation. Administer isotonic fluids, e.g., Ringer's lactate, to maintain adequate perfusion. Monitor for signs of fluid overload or inadequate resuscitation. Pain management. Provide adequate analgesia, often with opioids. Nutritional support. Initiate early enteral feeding, preferably via a nasojejunal route, once nausea and vomiting subside. Avoid parenteral nutrition unless enteral feeding is not feasible. Electrolyte and metabolic correction. Monitor and correct abnormalities such as hypocalcemia or hyperglycemia. Hammer 3. Specific interventions. Gallstone pancreatitis. Perform early cholecystectomy once the patient stabilizes. Consider ERCP within 24 to 48 hours for suspected cholangitis or persistent biliary obstruction. Alcohol-induced pancreatitis. Counsel on alcohol cessation and refer for long-term support programs. Hypertriglyceridemia. Initiate triglyceride-lowering therapy, e.g., insulin, heparin, or plasmapheresis in severe cases. Drug-induced pancreatitis. Discontinue the offending agent. 4. Monitoring and prevention of complications. Local complications. Monitor for pancreatic necrosis, abscesses, or pseudocysts using imaging. Manage infected necrosis with antibiotics, e.g., carbapenems, and minimally invasive drainage if indicated. Systemic complications. Monitor for multi-organ failure, renal, respiratory, cardiovascular. Provide intensive care for severe cases with organ dysfunction. Prevent infections. Avoid prophylactic antibiotics and sterile necrosis. Thromboprophylaxis. Use low molecular weight heparin in immobilized patients to prevent venous thromboembolism. 5. Discharge planning and follow-up. Lifestyle modifications. Advise on alcohol cessation and a low-fat diet if gallstones or hyperlipidemia are contributing factors. Follow-up imaging. Assess for resolution of complications, e.g., pseudocysts or necrosis as needed. Chronic management. Screen for long-term complications such as diabetes or chronic pancreatitis. Key considerations. Severity and etiology guide management intensity and timing of interventions. Multidisciplinary care, gastroenterologists, surgeons, and intensivists is often required for complex cases.